Houston, Galveston. And
Okay, we're ready whenever you are.
okay, yeah, I'm ready, Denise. So, well, thank you for inviting me to this. My name is Kyriakos Markides. I'm a professor at the University of Texas Medical Branch in the Department of Preventive Medicine and Community Health. And I was asked to talk about EthnoGeriatrics. And as we know, that's such a growing field. Not just the care of the elderly, but the demographics and the health status of the population. So there is a lot of exciting work going on, and I will speak to you about some of our work we're doing with Mexican American elderly in the southwestern United States in a minute. First, I want to just give you some numbers on minorities in general. If you look at 1980, 80% of older people were whites, non-Hispanic whites. In 95, 74. In the middle of the century, 67. So there is this growing diversity of the older population that we need to be paying attention to. We haven't really done a great job so far in planning for the future as the population is getting older and it's getting more diverse and has various groups have different needs. Another way of looking at the older population and projections is to look at the actual numbers. You'll see that in this year, 26 million older people are white, and not that many yet are minority groups, Black, Asian, Hispanic. But look at the numbers as we move in the next 40 years. You're going to have more Hispanic older people than Black. That's 10 million people. And we're just talking about older people. Now, if you look at the Hispanic population, which is of greatest interest to us and the people in our sites out there, I know some of them are on the border, 49% of the elderly are of Mexican origin, 15% are Cuban origin, 12% are Puerto Rican, and other Hispanic is 24%. And this other Hispanic category is getting larger and larger. We know very little about it because it's a variety of groups, especially from Central American and Caribbean countries. And they're too small to be really part of the huge studies that we would like to do and collect data on their health status. The Cuban population is actually smaller than the Puerto Rican, but in old age, the Cuban population is older. It's actually older than the general population because of the immigration experience of Cubans coming to this country in the 1960s. But again, that's the breakdown of the Hispanic population in rough terms, not giving you details on the smaller groups that are growing. Now, when we look at the African American population, it still continues to be the most disadvantaged in their health and life expectancy of all the groups. And African Americans live 5 to 7 years less than Anglo Americans. And that's not the case with Hispanics and Asians, and even the American Indian groups are beginning to improve relatively to population. It is a low life expectancy population, and then except at age 85, by the time you get to be 85, we have found that the few Black people that survive to that age tend to be hardy because, weaker people were selected out through mortality earlier. And again, the 85 plus population is very, very interesting because that is the fastest growing segment of the older population. As we're living longer, we're getting more and more people who are 85 and over. And as you know, especially the clinical people, that's where a lot of the health problems are really concentrated. That's where the long-term care needs are very important. A lot of people are demented. They need caregiving. These are big, big issues that we are addressing or beginning to address as a society. And these numbers will be growing in population in general. It's widely known that one of the biggest problems of African American people and the elderly is hypertension. Diabetes is high, obesity, rates of obesity are also high. And they tend to be, the older people tend to be more functionally, physically disabled. And functional disability is something of great interest in aging because it is what we want to prevent or reduce the consequences of it so that people can remain and live independent lives. So if anything we do in aging or in geriatrics if we can be successful in postponing disability, reducing disability, and reducing the burden on the person and on the families, is something that we need to be thinking about. The other thing about African American elderly, very few go to nursing homes, just like the Mexican American elderly. There may be some reasons there, and we believe that as we all hopefully live longer, there will be more need for long-term care in the minority populations. A little bit about Hispanic elderly, and I don't want to be lumping the groups because they're very different. I said low life expectancy. That's not true. I meant to say high life expectancy. The Hispanic population, all the Hispanic population have done a great job in improving their longevity. And we don't understand this very well. We don't know why, because it's an underprivileged population. And all the characteristics of poverty and so on should produce a lower life expectancy. But for some reasons, it is nice to see that there has been an increase in life expectancy to the point of the Anglo population probably. And part of that is because a lot of Hispanics are immigrants. And we are finding more and more that immigrants who come to this country are healthier than people that stay back or people who are here. So there is a healthy immigrant selection going on, and that translates into certain positive things about the population. At the same time, as people working in the Valley and in San Antonio know, the rates of diabetes in Mexican Americans is very, very high. It's 2 to 3 or 4 times the Anglo population. And it is also high in older people. And Mexican Americans and Puerto Ricans. Cubans are not different from the general population. They have lower rates. Again, obesity is a big problem, and it does correlate with diabetes and other problems. We also are finding that older Mexican Americans are physically disabled, more disabled than the general population. And part of it is related to diabetes and consequences. Part of it is related to other issues that lead to more disability. And again, low rates of institutionalizations. Then the nursing home is kind of a foreign institution in the Valley and so on. And I don't know how many there are, but again, with changes and out-migration of younger people sometimes from Hispanic areas, we need to look to the future and think about long-term care and alternatives to it. Another issue with Hispanics and other immigrant groups is low Medicare coverage. Just about every American who works, born in this country, gets Medicare. Now, there is a sizable minority of Mexican Americans and Cubans and Asians who do not get Medicare because they migrated to this country recently. And we're finding in our studies with Mexican Americans that they're at high risk of other things like mental health problems, and they don't speak the language. These are people that come late in life to live with their children who immigrated later. So there is a small segment of that older population that needs attention, and it's not well covered by insurance. When we talk about Asian and Pacific Island, again, I made a mistake and I said low life expectancy. The life expectancy of most Asian origin populations is higher than the general population. They tend to be, in many ways, economically advantaged. There may be some migration selection effects that make for higher life expectancy. And related to that, reasonably good health, as far as we can tell. I mention that because there haven't been really good, big national studies of Asian groups, because there's so many Asian groups, and they're much more diverse than the Hispanic groups. And so we have not really done big studies on them to really get a good handle on their health and health status. But whatever we know tends to be some positive things. And there are some negative things, and there is a lot of diversity. There are some Asian groups, the Cambodian and Hmong, for example, that are very, very impoverished and need special care. And the Native American population, mostly American Indian, there have been some positive things here with improving life expectancy, and but diabetes tends to be very, very high, and that's why diabetes is high in Mexican Americans, because of the American Indian admixture. there is something there, and as you know, like the Pima Indians in Arizona, for example, just about everybody gets diabetes. And again, obesity, which Daniel lists, is an issue. This population is kind of unique from the other groups because of the very high accident rates. Not necessarily in the elderly, but there's so many people that die of accidents. Years ago, not many years ago, accidents was the #1 cause of death on the Navajo reservation, for example. And again, there are some improvements here, but a lot of older, poor, American Indian, Native American elderly with problems that we have not really studied very well in terms of big epidemiologic studies like I'm going to show you we're doing with Mexican Americans, because they are small populations, tend to be scattered around the country, hard to study in a big way. What I'm going to do now, I'm going to speak to you guys about the study we started in the 90s of Mexican American elderly in the southwestern United States. And it's a longitudinal study. We got funding in '92 from the National Institute on Aging, and we are funded through 2003 to basically study the health status and health needs of Mexican American elderly in the Southwest, and then follow them up every couple of years. And of course, as you follow people up in old age, you lose subjects to mortality, although that's something that we are studying also. And I would just show you some of my colleagues in Galveston working with me. We have a nice team of PhDs and MDs, statisticians, and we also have a team right here in San Antonio, headed by Dr. David Espino from the Department of Family Practice, some of you may know, and Dr. Lichtenstein from the Department of Medicine here, and Tony Miles, also from Family Practice. And then we have a couple of people, Ron and Jacqueline Angel at the University of Texas in Austin. So I wanted to acknowledge their contributions to our study. What are the specific aims of our study? Well, we wanted to get, to begin with, prevalence estimates of medical conditions and disabilities and mental health, and so that we can compare that with other populations. Then we wanted to go on and follow them up and study changes in their health and disability rates as they get older. Now, that was our purpose. And as you go over time, you can study changes, and these are some of the predictors of people's health and health status. You can look at, support system, psychological, demographic, migration history is a very important one, stress in their lives, access to medical care, and of course as we go on, and we have mortality over 2 years. Now we just finished a 5-year follow-up, so we can predict mortality over 5 years. Now our sample came from the 5 southwestern states: Texas, New Mexico, California, Colorado, and Arizona. And we wanted to just get a sample that was representative of all Mexican Americans. And the way you do that in this kind of work, we basically use the census information on counties and neighborhoods, and we sample and end up in specific areas, and we screen for older people, and we study them. And we began with 3,050 people in 93, 94. That was our baseline. And I will show you some findings, some general characteristics, and you will see some issues that pop up that would be of interest to you, especially those of you who see patients and older Mexican American. Now, our sample is 65 to 99 to begin with, more men than women, which is the case in old age, very low education, and almost half born in Mexico. Marital status is what you might expect. Living arrangements, there are a lot of people in this population that live alone or live alone with their spouses. There is kind of the stereotype that Mexican Americans live with their children. Some do, but not all of them. There are a lot of people who are vulnerable because of they're alone. They don't have family around to live with them, or the family may be in the neighborhood. Some characteristics, primarily a Spanish-speaking population. And sources of income, I want to point out, is primarily Social Security. I mean, this is not a wealthy population. You will see that most of them are really making below $15,000. This was back a few years ago, but nevertheless, a very low income population, which really translates into all kinds of other access issues. And there is the Medicare. We're estimating only 87% of Mexican American elderly in the Southwest have Medicare, whereas the general population is like 99%. So there is a minority, it's not that many, who don't have it, and many of them are recent immigrants, and many of them are women who moved to the United States from Mexico to be closer to their children, and they're not very well covered, and very few have private insurance in addition to Medicare. When you look at the Anglo population, just a vast majority, like 80% of older Anglos, or non-Hispanic whites, have supplemental insurance. And you don't see that in the minority population. So Medicare does not cover everything, as many of you, all of you probably know. Selected characteristics, these are like self-reported. And I just wanted to point one thing, diabetes, 25% of men 65 to 74. It's probably an underestimate because there's a lot of diabetes that is under-detected. But what I wanted to point out to you is a drop from 65 to 74 to 75. There is a lower prevalence of diabetes among the very old. And the reason is because of such a devastating disease that a lot of diabetics do not live to be old. And that's something that is more the case with the Mexican American population, because not only does the population have more diabetes, the diabetes leads to more complications than in the general population, and it's associated, of course, with heart disease mortality. Other things are not terribly different. Hypertension, this is, for men, it's about what you get in self-reported surveys. Of course, we actually, when we talk to these people out there in the community, we didn't just ask them about their health. We took some physical measures like blood pressure, and I'll show you some information about that. We also took measures of their physical function. There's some simple tests that researchers are using, and also geriatricians who see older people, that I will talk about a little bit later. But this is the women. Again, you see that drop in diabetes prevalence because, again, diabetes is so devastating and associated with high mortality in this population. Other things are not terribly different. We believe, from the general population, we believe that hip fractures are a little lower, which is a positive because of bone density, better bone density in Hispanic or Mexican American women than in the general population. But again, and of course, men have lower hypertension rates and lower arthritis. Women do have higher rates of those conditions. Diabetes is about the same in men and women, and of course, heart disease is higher among men. Physical function, these are like activities of daily living. We all who work in aging know what that are. The basic activities of daily living is self-care, whether you're able to go to the toilet by yourself, to eat by yourself, to dress, to bathe, to transfer from a bed to a chair. When people are not able to do these things, they become dependent. And somebody has to take care of them, or they end up going to a nursing home. We are finding, however, over time that there are a lot of older people who improve. So it's not like one-way road toward more disability as you get older. A lot of people do improve their function. Right here, I wanted to show you how the Mexican American population in our study compares in some of these simple but very important functions. And they tend to be more disabled in just about everything than the white population. And they tend to be kind of similar to the African American population. Okay, they're better on a couple of things, but worse on a couple of things. So that's what we feel is the case, is the Mexican American population is kind of closer to the African American population in old age in their ability to physically function and perform activities of daily living. Now, when you look at other activities, what we call instrumental activities of daily living rather than the basic one, things like, meal preparation, shopping, using a telephone, being able to do housework, you will see that our population does poorly. The Mexican American population does poorly compared to the white population, and to some extent compared to the white non-Hispanic population. Now, another issue that is a big problem, and we're just now beginning to get a handle of it, is we believe there's a lot of undetected depressive symptomatology in older Mexican Americans, especially in women. This is like a simple measure of depressive symptoms called the Center for Epidemiologic Studies Depression Scale. A lot of studies use it. It's not really a clinical tool, but it gives you an idea, and you will see that we are estimating that 31% or two of the women and 17% of men are in this kind of a high risk category, and they're not all depressed, but there is probably a lot of depression that goes undetected, and it's a very powerful variable. I mean, it does correlate down the road with things get worse for people with depression, physically and emotionally, and they die faster, and so that's something we're very interested in. Being a study that does a little bit of everything, I mentioned we had like blood pressures, and we measured blood pressure, and we think that the prevalence of hypertension in the Mexican American population is, at least in the elderly, it's about the same as the non-Hispanic white elderly. We used to think that in the older days that it was less of a problem in the population in general. But whether it was less because we didn't really do the studies right, or whether things have changed over the years, we don't know, but we think it's about the same. But what makes this population different, as far as we can tell, is that there are more people who are unaware of their hypertension, and in other words, we measure them to be hypertensive, they didn't know about it, and that's more the case like with the general population based on other studies. So there is an issue here of really screening people, and we do know that the population does go to doctors. Older Mexican Americans, by and large, they go to doctors because they have Medicare. So those are some of the factors related to that. And we also, another paper analysis of our data, our colleagues found that there is a tendency to be undertreated. So we found, which is related to this, a lot of people who are hypertensive. Clearly, by the way, we measured them in their homes. We took 3 measures, and that's typically how you do that in studies, who were not on medication. And we don't even know about compliance very much, and that's something we want to look into. You get the medication, but do you take it? And a lot of older people don't. And for reasons like memory, there's a memory thing there that when memory begins to go, sometimes you forget to take your medicines. Another thing that is kind of intriguing, we're able to look at the Mexican American elderly population in the 1990s and compare our findings to a study that was done in the 1980s, the Hispanic Health and Nutrition Examination Survey, which covered the same area, had a similar sample, 2 hours. So, and we were looking at cardiovascular risk factors. But I want to point out one of the things that has really changed, and it's changing all over in all populations, the rates of obesity have gone up in Mexican American elderly, in African American elderly, in elderly in general. They have gone up in children, they have gone up in every age group, and it's kind of actually a worldwide epidemic, and nobody is really paying as much attention to overweight and obesity because, as you know, it correlates with so many problems like diabetes, like hypertension, like physical function problems, and so on. That's another thing I think we need to begin paying attention to in this population, find ways of maybe reducing obesity, and not so much in old age, because if you're obese in old age or overweight and you're 85 or 80 years old, it doesn't really matter anymore. And I know that my clinician geriatricians, when they see overweight older people, they don't put them on a diet. They just feel like it's probably unnecessary. But obesity in middle age and in the younger years and among children is something that is leading to problems in the later years, and we're beginning to slowly understand that. Yes, sir?
Depends on the degree of obesity.
Yes.
It's not recommended to have somebody losing weight
In,
If the degree of overweight is not that much after
Exactly.
55, but
You
if
have
you
to-
see somebody who's quite overweight, certainly.
oh yeah, you're right. They do. And but if somebody's 80 years old and is obese, he's got something going for him, and to live that long. But you're right. I mean, most clinicians would not tell people to lose weight if they're overweight, but maybe if they're extremely obese, there will be benefits to losing weight. I talked about depression earlier being a big problem in the Mexican-American population. At least we think it is. And we are adding new instruments to our study as we go back to these people to get more of a psychiatric diagnosis and get a better handle on what is going on. But when you look at these depressive scores that we have on these people, and these are instruments where we ask them about, how depressed they're, sad, and appetite, the typical symptoms of depression. And you look at your extreme category and you try to predict outcomes down the road. We are finding that, controlling for a lot of other things, people who are depressed, controlling for other physical conditions, controlling for medical conditions, controlling for everything else, people who are depressed tend to develop disability down the road, and physical disability. And that's really intriguing. And not many people have shown that, but depression in old age and in the younger years takes its toll on people, directly possibly, or indirectly, because depressed people don't get out and do things, they don't engage socially, they don't exercise, and they don't take care of their health. So it's something that we are looking at and others are looking at down the road, how depression might influence health outcomes. The other thing that we looked at in one of our analyses, we looked at depressive symptoms predicting mortality. Again, controlling for all the risk factors and medical conditions, at least for just the short term. It's a very predictive variable of whether you live or you don't. And we also found that depressed diabetics were like in double jeopardy. If you have diabetes, and you're more likely to die down the road. If you have depression, you're more likely to die down the road. But if you have both diabetes and depression, there's kind of a synergistic effect where there was, their survival was reduced significantly compared to other people. Again, something intriguing and something to kind of look into, this link between psychological factors and physical factors. Traditionally in aging, we've been studying how physical health influences your depression. And there are strong effects there. Now we're beginning to look at your emotional states and how your emotional states, like depression, like anxiety, like your sense of self-esteem, how they are actually influencing physical outcomes down the road as more and more studies become longitudinal. We used to just study aging by doing cross-sectional studies, like one point at a time, compare older people and younger people. That's really the wrong way to do it. You need to kind of follow people around as they get older, like we're doing with our study. And the other thing that is really becoming a big issue, and it's becoming a big issue for geriatricians and people who take care of older people, is we're realizing how important the lower body really is and how important it is for clinical people to assess, and there are simple ways to do it. Geriatricians do it, general people may not. And once the lower body fails, things just rapidly deteriorate for people. So people who see older patients know that. There are some simple tests that we did. One of them is you get people to walk 8 feet. I'm sorry. 8 feet down in the room, and we time them. And of course, most people do it fine. But there is a variance in the speed according to which people do it. You will not believe how something as simple as that, how predictive it is of their dependence down the road, of disability. Another test we do is we have people get up from a chair 5 times, and then we time them. Again, most people do fine. They can get up, but there are a lot of people who are actually not even able to do it, and they're the worst off. Then there are the people that cannot walk. They're the worst off. Then there is balance and tandem balance we do that is also very predictive of things. And here what we did is among non-disabled people in terms of their activities of daily living I was talking about earlier, among non-disabled people, these simple tests of their physical function, controlling, adjusting for conditions and disability, and medical conditions and other risk factors, the prediction of subsequent disability is very strong. And also we have a paper that I'm not going to show you now that, again, the lower body predicts mortality down the road independently of medical conditions. And so the point we're trying to make with this kind of work and other people who do this kind of work is really the importance of assessing people's physical function. You may not always get your patients to walk across the room, but really observe how they are able to walk or to get up, and because these things are really correlated highly with the negative outcomes down the road. Now, the study that I'm talking to you, we began in 1993-94 with 3,050 people. 2 years later, we went back, re-interviewed them, re-examined them, excuse me, and we ended up with 2,439 people. Most of the rest died or kind of dropped out of sight. We couldn't find them. And then we just finished a third wave of data collection this year, or this past year. And so we have 5-year follow-up data. And 2 years later, we'll have 7-year follow-up data. Now, people are dying, and of course we are, excuse me, studying that. And this is kind of a map of what we're really trying to do. The ultimate thing is going to happen to everybody. They're all going to die at some point. And I don't know if we're all going to be around long enough to, to be studying them. But I want to point out some of the important issues in aging. And one is cognitive status. We know very little about cognitive status in minority population. The instruments have been developed in middle-class Anglo populations, like the mini-mental status exam. These things that we use in the office or we use in studies are really biased against people of certain ethnic groups and against people who were not very literate. So we don't know much about cognitive status. Well, cognitive status is very important in people's functioning, and it's also a predictor of possible dementia down the road. So we don't really know enough about dementia and in minority populations because we haven't really done the studies. Functional status is the other area that is important. I just talked about physical function, and that's what we mean by that. If you're not able to take care of yourself or do your business, you're going to be dependent on somebody. If you're lucky you have somebody to take care of you, you do fine. Otherwise, you may end up in an institution. And the institutionalization is something we're trying to get a handle on because not many Mexican Americans are in nursing homes. But as we get older, our study gets older, our population gets older, we will trace them. We're going to track them down, the few, and find out how they're different. There have been some studies by colleagues in San Antonio of Mexican American residents of nursing homes. They tend to be more physically disabled than Anglos in nursing homes. And the reason we believe is that families, Mexican American families, are more likely to want to keep their parents in the home, take care of them, unless it's really, really bad. Things get really, really bad. So we think that there is a problem there. Very few are in nursing homes, but the ones that are there are really physically disabled in a bigger way, which also translates to another fact that we're finding out, that because not many physically disabled Mexican Americans end up in nursing homes, then somebody must take care of them. And it's the family that takes care of them. It's their daughters. And the sacrifices made by families are incredible in all groups, and especially, and it falls on middle-aged and older women, and which has negative consequences on their own lives. Sometimes they have to quit their jobs, and kind of minimizes their financial, status in older age by not working in middle age, and depression or emotional status, I should say, in general. We're finding out that it's really very, very important in all populations, and the interplay among all of these things gives us kind of a whole approach to a person and what we can do about it to improve all those things or to minimize their consequences. And of course, we're interested in the background variables and their medical conditions, support systems. So we hope as we follow this, this is by far the largest study of older Mexican Americans and it's representative. We're learning a lot of things, and I've only really shown you a selected number of analyses we've done. We have many publications in many areas, and I will be happy if you would send me email. My email is my name, which is Kyriakos Markides, at UTMB, which is on the first slide, and it's on a handout actually. At Kyriakos.markides at utmb.edu. I'll be happy to share specific analysis with anybody here or out in our sites. So I think that's all I have, and I'll be happy to discuss any questions you may have.
Some of these are findings in the internet, and these are particular study?
No. Some of the manuscripts, journals, I don't know. We have a lot of publications, and I'll send you a list.
Predicting factors like the 8-walk step, the standing and sitting, standing and sitting.
Yeah. Some of the journals, the scientific journals where we publish our manuscripts, you can retrieve the manuscript of the internet. But I can't tell you which ones, but I'll be happy to send you a list of all the manuscripts so you know where to look. And of course the libraries have them, and again, I'm very happy to share, send copies to anybody who might be interested. Any other questions? That's it. Okay, well, thank you.
I think I'll have to operate to check and see if any of the sites have.
Oh, I don't know. Where's our technical people?
I think we would be able to hear them, and then he would just click on.
Can we ask them?
Sure.
People out there?
Anybody hear us out there?
Edinburgh can hear just fine.
Oh, okay.
Do you have any questions for our speakers?
Edinburgh has no questions for the speakers. Thank you. We can hear fine.
Great.
Thank you.
How about Kerrville? Kerrville, do you have any questions?
How do you get to Kerrville? Oh, there he is.
Edinburgh has a question.
Okay.
Stage 4. The lettering was small and it could not be read. Stage 4.
Oh, stage 4 on this? Mortality. On this figure I have. Basically, stage 4 is mortality. It just says mortality. It's kind of like the ultimate event that is going to happen to everybody. And we're studying it, of course, as people are getting older. And we're able to predict it along with, other. Do you see it now?
Stage 2 presents that stressors and transitions of major life events. Widowhood and financial strain.
Yes.
Does that also include economical strain?
Oh yeah, financial strain, basically. Yeah, that's what we mean. Income is one way to get at financial strain, and a lot of these people have poor income. But what is really, yeah.
In the event that it is indicated a financial strain, is there an alternative that we can work around that so that the condition is not as heavily stressed or burdened?
Well, I would like to see people make more money. I guess that would really because a lot of older people who just rely on Social Security, like this population, do not really have high incomes. The way we get our financial strain, there are some simple questions that ask them whether they have enough money after they pay their bills to buy food. And there are a lot of people who are not able to really buy all the food they need. And the financial strain questions are very powerful, very powerful. They correlate very highly with especially depressive emotional problems. So it is something that it's very important. And I don't know how you prove that. Hopefully we'll be nicer to our older people, and hopefully as more people get private pensions, things would improve. But if you rely on Social Security, and it's tough, and a lot of the population, this population, the older population in general is doing very well. The incomes of older people have never been higher. The generation of people 65 to 70, maybe they are the wealthiest older people that have ever lived, and maybe the wealthiest old people for some time to come. But we have certain groups like Hispanic, Mexican Americans, African American Indians, who are not benefiting from pensions, so they have to live on Social Security. So there are a lot of problems, and yeah, I don't want to minimize, this issue. It's a very important issue because it does correlate with problems, health and mental health and so on, and isolation and reliance sometimes on family. The other thing we're finding with low-income populations, talking about finances, is there's reliance by younger generations on them because they don't have very much money, but they have maybe the only steady paycheck in the family. So you're finding situations where there is some dependency in minority populations on the older generation, and not always the other way around. The stereotype is, younger people take care of their parents, and it's not necessarily always that way. So yeah, that's a big area. Yeah. Curvio? Or
West Texas, are you any questions?
they went home.
I have one more question.
Yeah.
Can you put that table up on the chart, please?
That figure? This one?
Yes, on stage 1.
Yes.
Mentions socio-demographic variables, age, gender, social class,
Yes.
acculturation.
Right.
In acculturation, how would that be described? I mean, into what depth would acculturation be described into by mentioning acculturation and the migration history under stage 1?
Acculturation, yeah.
Is this what mass area are we looking into here? Is that just a large population, or is just a specific class in general?
Okay, let me just say something about acculturation. It's actually a controversial concept because it basically looks at people who, let's say, immigrate to a country and then...
Does that include one race as a culture, or we're speaking several races here?
No, we're just talking about Mexican American elderly.
Okay.
So some of them, they're more acculturated in the sense that, let's say, they speak English. But by and large, this population is very traditional, older people, as you know, down in Edinburgh. And so they are very traditional, primarily Spanish speaking. And so we don't really have a lot of change or variation on that variable. Now, I want to talk to you about migration history because that's really a critical variable. And I was talking about earlier that there's some issues with migration in general. When people immigrate, I mentioned earlier that they tend to be healthier and because they may be selected. But that takes place when people immigrate early in life for occupational reasons. We do have some interesting findings that I can show you about recent immigrants. Recent immigrants, both men and women, tend to really adjust very poorly to this country, you know, because they're coming in their older years, and the reason they're coming is to be with their children, and maybe they're dependent on their children. So, and they don't even have insurance, they can't speak English. Not that they necessarily have to speak English if they are really living in Hispanic communities, and there's a lot of Spanish. But immigrants in general tend to really do very well health-wise, but not so in when they come in the older years. And we're kind of looking at this population because it's very interesting, and they're very underserved and undercovered, and have a lot of problems that we don't really understand. So migration history is important. And nationally speaking, immigrant health is becoming such a big field because there's so many people immigrating to this country from such a variety of origins. And so there is a lot of interest in learning about them, their health status, their values, healthcare needs, the cultural factors that might influence our ability as a society to provide good medical care and social care and other services. So yeah, that's an important area. Okay. Oh, okay. Thank you very much. Enjoy speaking to you.